First of all, I would like to thank the organization committee and Canon Medical for inviting me. And thank you for your kind introduction. And sorry for my English. I'm a Spanish woman and I'm trying to do it my best. Okay, so let's see how it goes. I have divided my speech in these 4 sections. I want to talk about our daily activities in the club, when we usually perform MRI and how important is an accurate diagnosis. Then I will say when we usually use the AI solution, Canon AI solutions. I will talk about some cases of joint pathology and muscle injury where it's mandatory to obtain high spatial resolution images in sports medicine. And finally, I want to introduce you our work about the healing process in the muscle injury. Please not take any photo. This slide is from 2020, 2022, sorry. There are some names that have changed, obviously, but the most important thing in that slide is that we have a role in the organization chart of the Football Club Barcelona. This is our department, Diagnostic Imaging. And we work with more than 5,000 athletes because we don't work just with football or soccer. I don't know how you say. We work with 5 professional sports, 9 amateur sports. We have all these teams. And during these seasons, in 7 seasons, we had 2,025 muscle injuries. It's not bad. We work with these Vantage Galant 3 Teslas with AI. And this equipment is located in this medical department that is inside this huge Joan Gamper Sports City. And as you can see, our center is close to all these fields where our players are training every day and every weekend, and they are playing competition. So let's see, it's an old video, but also it explains very well our role about what happens in Football Club Barcelona when a player gets injured. Let's see.
Oof. We've just seen that again, and that possibly even a straight red if the referee sees that.
Quan un jugador cau al camp, si l'àrbitre ens dona pas, doncs sortim a peu de gespa i el primer que fem és preguntar al jugador quina sensació ha tingut, si ha sigut un cop, si ha notat una estrabada, si ha notat una punxada, i li preguntem exactament que ens assenyali una mica la zona anatòmica on ell nota aquesta molèstia. Un cop retirat el jugador del camp i passat al vestidor, explorat amb més cura, localitzem exactament el lloc de la lesió, fem una ecografia, que en molts llocs moltes vegades no veiem res perquè l'ecografia té les seves limitacions, i automàticament truquem al servei de radiologia perquè ens activin ja la posta en marxa d'una ressonància que normalment es fa a l'hora d'haver-se produït la lesió. Com que nosaltres sempre pensem els metges en termes d'anatomia, és a dir, s'ha lesionat aquest múscul en aquell lloc, en aquestes fibres, doncs pensem que la ressonància ens donarà el dibuix exacte de tot això que estem pensant.
Quan el jugador passa per la màquina, nosaltres estem mano a mano amb el metge de l'esport responsable i estem comentant les imatges. Just aquí és quan neix el cap llarg del bíceps.
Una lesió important,
Sí, Déu-n'hi-do. Llavors, ell és el que té tota la informació. Jo només tinc la informació de la imatge. Jo l'informo del que veig. Ell em va preguntant i es va fent una mica la idea de com és la lesió.
Actualment, amb la màquina Titan 3 Teslas, ens dona tota la profunditat de la lesió, estigui a superfície o estigui en profunditat del teixit, cosa que amb l'ecografia que fèiem fins ara només podíem distingir lesions que estiguessin fins a 4 centímetres, perquè l'ecografia en aquests moments no és capaç de distingir més profunditat.
Just quan comencen les fibres del bíceps, és aquí on hi ha la trencada.
Per nosaltres és imprescindible veure la localització de la lesió i quina part de teixit afecta. Llavors això t'ho dona la màquina i a partir d'aquí nosaltres podem estimar el temps biològic de recuperació d'aquesta lesió.
Les característiques del jugador, en quin moment de la temporada estem, quin tractament ha de fer, i llavors ell decideix quin és el retantòple que necessita aquesta lesió.
Has estat còmode amb la ressonància? Sí, a vegades hi ha una mica de claustrofòbia.
Una vegada ho ha decidit, surt moltes vegades el jugador i després el doctor Pruna o el doctor responsable del cas en concret parla amb el jugador del que s'ha de fer per recuperar aquella lesió.
Tu estàs fent un control de ressonància i dius, mira, està cicatritzat i en tal mesura. I, per tant, ara portem unes 4 setmanes. Encara que cronològicament no coincideixi, tu saps biològicament per la ressonància quan estàs del final d'aquesta curació.
As Dr. Pruna said, we started with a Titan 3 Teslas, but I think it was 5 years ago we changed and we started with the Vantage Galan 3 Teslas. And it was awesome because, as you may guess, we need to work with the most innovating technology. Because we need to detect exactly which ligament is affected, if it's partial or not, and if it has a role in the stability of a joint. Or we have to detect as soon as possible a small cartilage injury to manage the player as soon as possible to avoid the surgery. So therefore, we use the AI technology for all our MSK protocols, and obviously for the muscle injury, that we are reference center of muscle injury and we use it. To be honest, at the beginning I hesitated about the AI technology because I thought that it could create extrapolation issues or some artifacts, and I didn't feel well with it, comfortable. But one day, I realized that if we use it for all the sequences that we obtain in a protocol, I could obtain all these images in a high spatial resolution in the same time than a standard protocol. Here we have an example. This is the same player. On your left, there is the first MRI, the diagnosis MRI. On your right, is 15 days later when we perform the follow-up. And if you compare both images, as you can see, this one is sharper. So if we have to detect a small tear in an aponeurosis, that sometimes we can see vessels that cross this aponeurosis, and you have to say, okay, we have to stop this player because it has a tear. We need this high-quality image. Let's see some joint cases. This is a rugby player with problems in the knee. And, well, the physician wanted to rule out ACL injury. When we know that, we usually perform obliquity projections, okay? So we perform these 3 proton density sequences with FATSAT, 1 PD, and 1 T1 also. And in these 3 sequences, we can see that there is a tear. There are some fibers. In fact, the posterolateral fascicle has a rupture with retraction. And with 2 obliquities, the coronal oblique with respect to the ACL and the axial oblique, we can detect that the tear is at this level and is less than 50% of the ACL. Okay, thanks to this high quality, we can detect this kind of injuries. And in this case, we have to stop the player, obviously. The tendinopathy, it's a big problem for us, the tendinopathy. In 2019, there was a symposium on tendinopathy, and it was advised that not any intratendinous signal change has to be considered tendinopathy. In fact, tendinopathy is a clinical concept. The radiological features should correlate with the clinical perspective. So if we have a player with symptoms and we see tendinotic changes, I mean, this intratendinous signal MRI changes, what you have to look for as a radiologist is not these tendinotic changes. You have to look for loss of the structure, for a rupture, okay, for a partial rupture. It's like in this case. We have this axial view with this intratendinous signal MR changes, and inside there is a small cavity. We know that sometimes in the tendon, the cavities are ganglia or are tendinotic changes, and that's all. So in the sagittal view, we can see the same, these intratendinous signal changes. Something is wrong here, but we don't really understand what's happening. And in this coronal view, also we have the same, and also we see something like a waving sign. But thanks to this high-quality image, we can see that this guy has a rupture, a micro rupture, and we have to stop him 3 weeks, 4 weeks, because there is really a rupture in a tendon. If we see just this, we can say, okay, everything is inflammatory, we can go on, no worries, okay? The shoulder. This is the injury that we have more frequently in handball players, for instance, or in baseball players, or in rugby players, because in fact, 20% of the acute stabilities are perthes. And the perthes has the problem that it's very difficult to identify because the labrum remains in its normal position. So we need to detect this line that separates the labrum from the glena. Alp size, easy, no comments. And what about the GLAD? Glenolabral joint injury. We see the fissure that separates the labrum from the glena, and if we go distally, what we will see is that in the cartilage, there are something wrong. There is chondropathy, okay? So in that case, we had to stop this baseball player. Let's go to the muscle injury world, our world. As you know, or maybe not, I don't know, when we analyze a muscle injury, the question that we have to answer is the amount of connective tissue that is affected, because it gives us the prognosis of that muscle injury. How long has to be the return to play? The tendon, when extends intramuscularly, it gets thinner, okay? And we name it aponeurosis. And the aponeurosis sometimes is anatomically fragmented, and it's very difficult to see if really there is a tear or not. Sometimes the muscle injuries, like in this case, are too bloody. Here we have a hematome and too much edema. And the edema difficulties the analysis of the aponeurosis integrity. In this axial view, we will see here there is the aponeurosis that is going inside the adductor longus. And in some sections, we can have doubts about the integrity of this aponeurosis. We are going distally. We have here the hematome. And when we perform the oblique sagittal, following the aponeurosis, and with high spatial resolution image, we will see that the aponeurosis is intact. Good news. This player will be ready in 2 weeks. Let's see typical case in any club. It happened before we published our article about the pre-return to play MR signs that are warning signs. And this is a player, 17 years old, that he was playing a match, and during a sprint, he had pain in the posterior aspect, in the proximal portion of the right thigh. And we performed the MRI in less than 24 hours. And what we see is that there is an injury in the central tendon of the hamstrings, at this level, where we see that there is the waving sign of the tendon, interstitial edema, and also intermuscular edema. And in the axial view, we are able to detect exactly where is the tear, the amount of connective tissue, okay? Is here, in the posterior aspect of this central tendon. It's bad news. In fact, taking into account different factors, the medical department decided to use 8-10 weeks to repair this injury. But we had to change our mind, and 7.5 weeks later, we had to perform the pre-return to play MR. I think it's here, yeah. And in this follow-up, wow, everything looks fantastic. There is a continuous connective tissue, there is no edema, the tension is recovered, but in this axial view, we are following the central tendon, and suddenly I saw, because this player was, in this case was mine, I saw this small tear proximal to the previous injury. When I saw that, I called to the physician, "Eps, something is wrong. We cannot go on with the return to play." But what happened in every team, in every football team? Oh, Sandra, GPS, fantastic. The player has good feelings. The coach, the typical situation, the coach needs this player for the next match. I don't really understand why, but he needs this player. Okay, so we decided to go ahead. And he played the match 3 days later. And the 10th minute that he was playing, he felt the same symptom, the pain at the posterior aspect of proximal right thigh. And when we performed the MRI a few hours later, we can confirm that there was a retear. Well, the success of this case and some cases that we lived, was that the physician called me and said, "Okay, Sandra, next time we will stop the player." Oh, okay. Let's see how often the recurrences in muscle injuries occur. Last year, Extran and colleagues, they performed fantastic epidemiological works, and it was about the hamstring injuries. And they said that out of all hamstring muscle injuries, 18% were recurrences, not bad. And specifically, the early recurrences made up 69% of these 18%, okay? Obviously, it's more frequent during the matches than training. And the authors concluded saying, okay, the player has to complete the rehab and managing the load during the trainings. Yes, but the most important thing, and I think that target, is this one. We should respect the biological time of the healing process. And to do it, we need to understand what's happening and how is progressing this healing process. And it's mandatory to read everything about Jarvinen, because he's doing very well works in vitro about the healing process, and he demonstrated that there are 3 phases. At the beginning, destruction, repair, and remodeling. And he was able to see that few hours later, you have your injury, few hours later, you start to heal, okay? So if you start to heal hours later, I thought, okay, maybe we can see if we are able to detect these healing changes. We aren't able. We can see something the 8th post-injury day. At that day, we will be able to see the immature scar, the hyperintense center surrounded by hyperintense peripheral line. And we say, okay, we can do a work, we can do a follow-up of the healing process in different players, and we can analyze it in order to categorize the different phases using the MRI. And we did it. We analyzed 310 MRs, and we could see that there are 3 phases. This one, destruction, this one, immature scar, this one, mature scar, and finally, when the scar is remodelated, months later. But, okay, it's important, the scar, obviously, because if I'm doing the follow-up 1 month later and I'm still seeing this image, we will stop the player. But it's not just the scar. We need to understand the edema that surrounds the scar. And the thing is that we can see 3 different edemas. At the beginning, we will see the interstitial edema, the Federer sign that we see here. And it's when the fluid expands the interstitial intramuscular space, okay? The second one is the intermuscular edema, when it expands the intermuscular space and it has a laminar pattern. It's this peripheral hyperintense line, white arrow. And finally, the reparative edema is an ill-defined edema surrounding the scar. We really appreciate this edema, and we want to see this edema, okay? So if we are in phase 3, and instead of the reparative edema, we see still interstitial or intermuscular edema, well, something is happening. The muscle is not adapting correctly to the scar, so we have to stop the player. And here we have an example. I'm finishing. This is a futsal player with a tear in the lateral fascicle. And in the follow-up 3 weeks, there was too much interstitial edema that we had to stop this player. I think it was 2 weeks ago. And I think that on Monday, we will have the follow-up. And we had stopped it 4 days, the rehabilitation progression. And that's all. Here we have the take-home messages. Among professional athletes, we need to be detailed diagnosis to do detailed diagnosis, and we need the highest image qualities. With the new technology, in fact, I use the ACE, we obtain sharper images, sorry for the spelling, sharper images in the same or less scan time, usually in the same scan time. We need to ensure that there is a fibular tendon rupture. Remember that the tendinopathy is a clinical concept, it's not a radiological concept, okay? Partial ACL ruptures or labral disinsertions, in order to know exactly what will happen with this player the rest of the season. If we have to manage the injury right now, or we can wait at the end of the season. The most strategic role of sports medicine is the prevention of injuries and repairs, and it's necessary to use the best technology and detect signs of risk as soon as possible. And finally, I was talking to Valentin. I want to work with PIC or PIC, I don't know how to say it, because I think that it could be very interesting to use it in musculoskeletal. And that's all. Thank you.